you very much. If I'd known, Dean Rutherford, if I'd known that I've had introductions like that, I would not have taken 2 years to show up. So I think that I'm just going to make a sound loop of that and, share it with my mother and my students. They take me for granted, actually, a little bit. Not my mother. Not my mother. It is terrific to be here. This is my first time to Little Rock, and I have some friends here who are here tonight from this city, and this is such a beautiful school and library. And I had watched I read about it, and I certainly read the book that President Clinton sent me about this place, that it's really even more stunning, of course, to be here looking over the river and to see the library. So thank you very much for having me here. And I would like to say something I said to the dean earlier. The logic, the thinking, the commitment that went into the school is, of course, it will be my argument here tonight. This is exactly the kind of thing that we need so badly in our country and in the world. And I hope that I'm lucky enough to be able to work more closely with the students and faculty here. This is what we need to heal the world, to make things a lot better. And I'll give some examples today. And I'll try to go back to the role that students and the notion of service can play, and I'll be closing in considering that a little bit more formally and what role universities should play as well. I do, however, want to start with specificity. And that's the thing about these grand topics that Lindsay mentioned. And it's true that I have written a lot about them. And we did an interview I never forgot to ask you why the publication, school publication, is called Frank. We can save that for later, but I was being interviewed for the school's publication. And is that like Oprah? Naming maybe I haven't met Frank yet. And I was noting that the kind of discussions that we were having, and I've been having clearly with Lindsay through writing and through some of the work, it's a great privilege to have those discussions, the kind of discussion that I'd like to have tonight. What does it mean to have a right to health care or clean water? What's it mean to work on rebuilding infrastructure or building it where it's never existed before? In the everyday work that we do, specificity is, of course, critical. There are some people here from the medical center, some people who are medical students or residents. They know just what I'm talking about. So, interns too, by the way. So let me give some examples from specificity. I'm going to talk about one disease. This work is never about one disease. It's about pathologies of all sorts. But it's sometimes helpful to focus on one. And this is also, I hope, going to be a tribute to the work that I've been able to do with the Clinton Foundation and with partners in Haiti and Peru. Some examples. Now this is from, and some of you may find this useful in teaching. I do, but I also learned from it. It's from a website, worldmapper.org. I didn't even steal this. This is legitimate use. And you can see what it is. It's a computer modeling program that changes the size of, in this case, the nation state based on a specific problem. And I've just chosen AIDS, but if you look at maternal mortality, access to clean water, access to basic services, it would look very similar to this. And I'm just going to draw your attention to one continent, the obvious one, Africa, but also the island of Hispaniola, where I was lucky enough to go in between college and medical school. And that was 26 years ago. And you can see that Haiti, looking at HIV prevalence as a problem, that is the virus that causes AIDS, shows up as bigger than the much larger Dominican Republic. There's also some good news about AIDS in Haiti. I'll tell that as well. But this is a map of social disparities. Yes, it's a map about a particular illness, but look at malaria. Again, the list is long. Now, one of the tendencies that we have, I know I have it as well, everyone does, is to say this problem is so huge. What could we possibly do to turn it around? And I do feel that over the last couple of years, that question has been posed forcefully about no small number of problems in our economy, in this country, and internationally. The crisis around the environment. It's a question we ask a lot. What can we do? This school is, of course, has been founded to answer that question. How can we draw on the talent that we know is out there and bring it to social problems. I would put environmental problems under the list, social problems. So here's another big one. And I had, when I was 23 and went to Haiti, it really wasn't a problem. AIDS wasn't a problem in the rural areas where I was. I was at Partners in Health yesterday in Boston, and someone had put up on a bulletin board in our office a letter that I had written. It wasn't dated, but it was clearly, I would say 1986, because I'd written it to Tom and Loie White, a couple from Boston who would later become really some of my closest friends and would found that year actually Partners in Health. But it was a letter saying, I saw, maybe what's going to be the first case of AIDS that we've seen out here in rural Haiti. And, and I was 26 years old, and I was shuttling in this letter, which I said I want to make a copy of that. I was shuttling this patient around from place to place, and there's really nothing that could be done. There weren't any medicines, there weren't the diagnostics. And this was taking someone from rural Haiti all the way to Port-au-Prince. And, it's overwhelming. And I've felt that in Africa and in Siberia and in Boston. These are overwhelming problems. But they're problems that have some solutions as well. Now, physicians working, and again, I just invite you to look at the size of Africa. Africa goes from the swollen continent to a little narrow ribbon here. Haiti almost, disappears. Cuba gets large, et cetera. This is where, and part of the reason to show up this slide as the next one is not simply to say, gee, we need more physicians, although clearly we need more physicians and they should be better distributed. You could say the same thing about nurses or access to healthy heifers. You can tell the other reason I'm here is to see my friends across the street. But physicians are not going to be the short-term answer here. They may be part. I was a physician in training in the 80s, but this is much more. This is recent data. This is now, and so again, one can be paralyzed by saying, "Well, we're never going to, do this with physicians." It's the same. The nurses, by the way, looks identical. There's not a significant difference. But again, is this the beginning of a conversation about what could be done, or the end of one? And it's got to be in public service and taking on public problems of the public, not necessarily as public servants, but as the private sector, as NGOs, as church groups. This needs to be the starting point. Assessing the problem and saying what can be done. Now, I'm going to give an example now of when the discussion gets slowed down instead of sped up. Because I said this, is this the beginning of a conversation with anyone? Well, and I'm not here to disparage economics. Heaven forfend. I mean, look, after all, the economic wisdom that we've seen in recent years has really done wonders for our national economy. I got to police myself, Skip, a little bit better on that stuff. I want to just talk about overly confident claims about social problems, and I don't. I'm going to give you a couple of examples from 2002, and the reason I'm choosing 2002, and I'll explain the jargon in here as well. Don't worry. The infectious disease people here, and also the students, some of them will recognize this. 2002 was in some ways the low point if you were worried, and I had been, as I said, for a long time, about this particular pathology, AIDS, in Africa. And I would also add that the reason that tuberculosis is so difficult to control in Southern Africa is also largely due to AIDS. So this is the low point. In 2002, to me, that seems like yesterday. Some of my students at Harvard Medical School think of this as, the era of Ozzie and Harriet or something. The Great Depression. Well, it was the Great Depression. There was I'm glad some people are warming up to my humor here. I appreciate that. So this was a time when people were saying, this problem's really too big. There's not a lot we can do about it. And PEPFAR, what that means is the President's Emergency Plan for AIDS Relief, which is President Bush's plan, hadn't come into being. The Global Fund which was to be really born the next year in my view, was the Global Fund to Fight AIDS, Tuberculosis, and Malaria. And what are those things? They're financing mechanisms to actually have this be the beginning of a conversation. But they didn't exist, and they were not dispersing money. Now I had gone, actually Lindsay asked me about this earlier in our interview, I had gone to an AIDS meeting. Every 2 years there are these huge AIDS meetings. Actually, President Clinton has addressed many of them. That's where I met him, in fact. It was this year in Barcelona. And I had, in 2000, I said, I'm never going to one of these meetings again. Because it was the first time there was one. It was held in Africa. It was in Durban, South Africa. And I'm from Florida, so I got there and I thought, wow, this looks like Fort Lauderdale, which is not entirely a compliment to the city of Durban. But this is 2000, not 2002, and I was part of a debate which was really, about, is it really worth trying to do this? And I thought, this is not a very comfortable debate for a doctor to have. Should we bother trying to treat the sick? And I left that conference a day early, which I had to change my ticket. I just didn't want to be there another day. I thought, this is not for me. I'm never going to another one of these. Then in 2002, they said, Paul, would you like to give a plenary address? And I said, oh, sure, I'd love to go. So I wanted to write every word of my talk out. I was working in Haiti, and I was on the internet, and I'll talk a little bit about leapfrogging technologies if we get a chance. And I found some of these articles that were in The Lancet. Now, I know all of you read The Lancet every week, and so you're very familiar with our medical journals. Don't you love the names of medical journals? They're like downwardly mobile names. You'd never know that this was a lead medical journal in the world. And I read this, and let me just say that HART doesn't matter what it is, it means highly active antiretroviral therapy. It's a treatment for AIDS. It's all we've got. We didn't in 2002 have other ones, and we don't have different ones now. So to argue that intervention A is more effective than intervention B, that's what we're supposed to do in medicine, study interventions and see how they might compare. That's what we need to do in our country now. What are effective and inexpensive interventions to promote health? But look at what this intervention is. It's really it's pitting prevention against care. And that's not a tenable situation for a clinician either. So I asked my research assistant in Boston, I said, I can read this text, but I can't see the footnotes. And as some of you know, who've been good enough to read my books, I love footnotes. I love footnotes. My idea of a good footnote is it should be at least 2 pages long, and I call those punitive footnotes, because it's sort of like, you want a piece of me? Come on, try my footnotes. I come from a very athletic family. I'm the only one I had to use footnotes to protect myself from, one of my brothers was a pro wrestler on television for 10 years. The Haitians look at him and say, same mother, same father. But anyway, that's a different story. So I was looking for the footnotes. You can't blame me. You need your documentation. And it turns out that this confident claim about intervention A being 28 times more cost-effective than intervention B is really based on another mathematical modeling exercise. And I've already shown you that I like mathematical modeling exercises. The maps are a mathematical modeling exercise. But that's not enough evidence to base a strategy for AIDS when AIDS is already in 2002 the leading infectious killer of adults in the world, and a leading infectious killer of children in the world. So this wasn't good enough, and this was also, as I said, this is the year that I met President Clinton. I'd known the First Lady a little bit working on a tuberculosis project with her in Russia, but I'd heard the President speak, but in 2002 I went to give my pitch, and I was, as I said, preparing, and I said, well, a mathematical modeling exercise, a proposed project. So I wrote back to Partners in Health and said, look, we have 4 years of experience treating AIDS in Haiti. How much do the drugs cost us in 2002? Because if you're going to use cost-effectiveness analyses, which is very important to do in my view, you have to understand 2 things. Now, I'm not a development economist or an economist at all, but it seems to me cost-effective analysis involves 2 things, cost and effectiveness. So effectiveness, there is no effective treatment other than HART, whatever you want to call it. So what are the alternatives? I mean, if you're from Berkeley, California, you can stare at a crystal or something, but it's not gonna treat AIDS, you know. And so, well, what about cost? Well, here was the answer given by the director of procurement at Partners in Health. Now, granted, at the time, she was the only member of the procurement team, but it sounded good to say director of procurement. She's still the director of procurement. Doesn't matter the details. There are two effective regimens here for 2002. Notice this is all 2002 data. And they're basically similar in price in the United States and elsewhere. Up to $10,000 per patient per year in the United States. But again, is this to start the conversation about drug pricing or to end it? Because already Partners in Health was getting the drugs with a mix of concessional and generic and a big pharma product for less than a tenth of that. So again, think about cost effectiveness. Well, if cost is all over the map and effectiveness, we've only got one effective intervention, then it's not a good idea to make confident claims about the cost effectiveness of an intervention until you've got the data down. And then the IDA, which is the International Dispensary Association, and this is before President Clinton lent his prestige to the effort to drop the drug prices further. Already, they had negotiated some regimens for about $1 a day. So is it $10,000 per patient per year or $300? It makes a big difference. Now, I would tell you, and this is going to be one of the punchlines, Lindsay worked on this project as well. The Clinton Foundation has worked enormously hard to make these drugs even more available, and they're now about, this year I think we're going to get them for $90 per patient per year. So next time you see your native of Arkansas, thank him for us doctors, nurses, social workers, and patients. Now, 2002, so notice I haven't even spoken at all about being a doctor. This is, dealing with the health economists who are deciding but that also matters, and you say nothing about being a member of a family, a parent. And I just thought I would, I've shown these other pictures before and after quite a bit because they're so dramatic. Actually, that guy up in the corner, his name is Joseph, that's his real name, and I remember I said I would never go to these meetings again, so then of course I said, sure, I'll go if I can give the plenary address. And then the next time I was invited was to Canada, and of course, instead of saying, no, I don't want to go, I said yes again. So I flew from Rwanda. I'll tell you how I got to Rwanda in a minute. I'll give you a hint, though. It involves Arkansas again. And I flew from Rwanda to Canada, and there were no direct flights. And I got stuck in Heathrow with a lot of people from Africa because this was the day someone decided that, I don't know, that body fluids would be good to blow up planes. But that's what they said, and I believed it, but we missed our connection. So the next day we get there, they've taken away our, you couldn't carry anything. I was reading a book, and they actually made me check the book with a little piece of tape around it, check it. So I had nothing. And I was a little bit grumpy when I got there. Not very grumpy, because I'm not given to grumpiness. But so I said, there were about 55 people from all over the Partners in Health sites, and there's 20,000 people there. President Clinton spoke again. But I said to my protégés and my Haitian colleagues, look, don't make me translate for the Haitian patients, because this guy, Joseph, came, and another patient right up there. And that's before and after pictures I'm sure you've gathered. So I said, don't make me translate. I mean, there are plenty of people here who speak, Creole, and you guys, these patients have never left the country before. They've never been in an airplane. They've never been in a hotel. Look out for them so that I don't have to do all the work. And I said that, and about half an hour later I came back, and this really serious young doctor is giving a talk to the people who've never traveled before, and I was listening, and he was saying, now, that's an escalator, and you got to be very careful, and you got to hold on the rail, and that's an elevator, and this little card actually doesn't look like a key, but it opens your door. And he said, but the most important thing that you need to know, and I leaned forward, never open the minibar. So, who says public health isn't funny? Anyway, that guy, who was dying in 2003, and I'll go back to his hometown and tell you a little about that experience. These people, it's hard to talk about cost effectiveness when you don't look at the impact I mean, we should talk about cost effectiveness, but what's the cost of doing nothing? That's what I'm waiting to hear more about. There's a cost to inaction. And here's another young woman, and I'll say a little bit about our treatment model, which is very complex in a second. It's so complex it may take me half an hour to explain why it works so well. But let me give it a try. Patient, pill, water, community health worker. That's the model. So if you hear, well, Partners in Health is really celebrated for its model, as our former president would say, it's not nuclear science. You know, it's not that complicated. Anyway, but back to economics. So what's the cost of doing nothing? This is 10 years ago. I was not speaking about the former president from Arkansas, by the way. You know, this is, it's a young woman who I've known since she was a teenager, and here she is, dying at home, and then, a year later, now she's back in the workforce, and she's a mom, she's got kids. So 10 years later, again, talking about having, Lindsay asked me, how do you get, let me answer one of your questions from the interview. How do we listen? How do we really understand what people who are themselves living in poverty are saying? One way is to just include people like her. Her name's Adeline, and listen to what she has to say. So we brought them up to Harvard. Again, they'd never been on a plane either, these two, and they gave a talk 10 years later, still on the same regimens they started. That's again called ART, antiretroviral therapy, and this is in front of 1,000 people at Harvard. And so I'm just saying, let's understand what the true costs of inaction are. This was also kind of a funny day because this is just last fall. This came off the internet. The internet's still a mystery to me, by the way, but you can get pictures from it. That's all people my age cannot be expected to know all these details. Actually, the man who got me on the internet, Marvin DeBooth, is sitting right here, and he said, you're a little older than I am. You got to admit I'd done good, right? He hooked me up in Haiti many years ago. Anyway, so the funny thing about this day was I was translating for them. Of course, you can, if you think I'm making this up, go and look at the Partners Health website and watch this. So she gives this incredibly, and the day before I said, do you want to talk about your speech tomorrow in front of 1,000 people and, help you get ready? And they said, no, we're used to public speaking. Let's talk about something interesting like, how about Obama? So I didn't get them to practice, but the next day I was sitting there, I was feeling quite relaxed actually, and he starts speaking. His name is Sankar, which means Holy Heart. I love these details. And he said, well, before I give my testimonial, I'd like to thank all you bourgeois people here for helping us. And so I just said, so the Haitians in the crowd and those who spoke Creole cracked up, and the other people didn't. They're waiting for me to explain what was funny. So I did my best. Now I've gone from health economics to individuals. Now I want to talk a little bit about programs. So this is what we did with the first Global Fund grant. This is the, actually, Ira Magaziner. President Clinton came to Haiti this year, 2003, as did Ira Magaziner. And we worked, this is again at a pretty difficult time in Haiti, but what we got one of the first grants, we being not Partners in Health, but Haiti. And so this is a lot of organizations and the Ministry of Health. And we got this big grant, and Partners in Health actually we didn't get the money on time, but we're due to receive $2 million to start this. It's a lot of money. And because it was delayed, we said, well, we're going to keep it on time anyway. We actually took, if you can believe this should make every NGO person squeamish, but we took out a loan from a commercial bank to start on time. So, and I was already, at this 2000, I was already 42 years old, and I had to get someone to co-sign for me. Tom White, in fact. Anyway, so we said, we're going to make sure that this is not what's called in public health a vertical program, just one problem, because people have many problems, right? So the vertical problem would be AIDS only or prenatal care only or whatever. So we said, well, we can strengthen the whole system if we do this right. We put in a laboratory, we get some essential meds in there, and I won't go through the jargon because I want to save time to talk, but it went from an empty hospital, like all these. This is a public hospital, by the way, and I'll return that. Lindsay and I talked about it. Went from an empty hospital to a full one because you put in good services and people come. And this is some of the numbers. Of course, the number of patients went from nothing to a lot because you're putting in services. People aren't dumb. There's a Haitian saying, we may be poor, but we're not stupid. Why would people go to a dirty, understocked, understaffed facility where there are user fees in front of them that block their access? And the answer is they don't. All over Africa, I've seen the same thing. I'll show you. And of course, if you don't have a test for HIV, you don't see it. So HIV detection goes from 0 way up. But look at a couple other things, like prenatal care or vaccine. This was not a vaccine project. It was a project that the funders called it an AIDS project. And we said, yeah, we'll show you an AIDS project. And of course, we wanted to strengthen all of the primary healthcare system, and that's indeed what happened. The good news is once we showed that this is possible, we were able to, as we call it, scale it up across central Haiti. Same model. And for those of you who know, as some people here do, have visited, and this is a laser, right? I love lasers a lot. And they have taken them away from me at Harvard because I keep pointing them at the students when they raise their hands. But anyway, and oops, I did not do that. Never mind. I see that clearly the people at Harvard have already communicated with the Clinton School. So the point that I'm making is here in the middle is Conge, where I've been living and working for a long time, but we never, I'm glad that we've built that hospital and schools. I'm proud of our work there. But it wasn't until we went into the public sector that we could go from the Dominican border all the way to the coast and really start reaching. You said we have served 2 million people. We serve probably 3 million people a year now, just in Haiti, because we're working in the public sector. Now this gets back to the rights issues that we can talk about later, but the next big question for President Clinton, and I hope you don't mind me talking about him tonight and the Clinton Foundation, was, okay, yeah, we knew you could do this in Haiti. Meanwhile, we're thinking, can we really do this in Haiti? He said, oh yeah, we knew you could. But what about Africa? I took this picture actually in Western Kenya in a school, and it really almost made me cry. I saw it on the blackboard. And what the teacher meant clearly was do not erase when he wrote save. But that's not what I saw, and I'm sure you can see what I, as an American, saw. And it was really disturbing to be in Western Kenya and to see what was happening there, and it's happening in Southern Africa as well. And that's how we ended up in Rwanda. President Clinton and others in the foundation said, let's go to Rwanda, and then Malawi, and then Lesotho, and then anyway. But we said, okay, and I remember the first time we went there, it was 2004. I had been there before, but the first time I went there to work, they sent us to a hospital in northern Rwanda, Ruhengeri, for those of you who've been to Rwanda, or maybe someone's from Rwanda. And I went to the hospital, and there were 3 doctors there, and electricity, and an X-ray machine, and a lab, and I went back to Kigali and said, you don't have to send us there. You can send us somewhere more difficult. I was at the Naval Academy a month ago. Anybody here go to the Naval Academy? No, so it's safe. I was at the Naval Academy, and the midshipmen I was giving a talk, and they were a little bit sleepy. It was early in the morning. They're supposedly all accounted for at night. I don't believe it. So they were kind of sleepy, and I told them that Partners in Health, we're sort of like the Navy SEALs of public health. And that was a hit from then on. Anyway, but we went back to Kigali, the medical director of Partners Health and I, and said, you don't have to send us there, where there's electricity and stuff. You can send us somewhere more difficult. And they said, okay. And so they sent us there. Now, you laughed, but this is really what we were trained to do. This is an abandoned hospital, and there's no services for 250,000 people. And unlike in 1982 or 20 years previously, we knew that we had to provide services, rebuild the infrastructure, train local people to do the work, and do some research that would tell us how to improve this. And so that's what we did. And of course, we also had the Haitian team, and this is what happened. These, for those of you who've worked in Africa, you know that this is what these wards look like. They're empty, they're dirty, etc. But again, it's not rocket science to fix these wards up and to make them work. Inshuti mu Buzima means Partners in Health in Kinyarwanda, as you all know. But as a joke, I'm not assuming people here. I can't speak Kinyarwanda, and I'm trying. But, and again, this was a partnership with the Clinton Foundation, the Ministry of Health, the public sector again, and Partners in Health. And it was the same story. You can't, for those of you interested in maternal mortality, which I hope everyone is, since 500,000 women die every year in childbirth, you can't solve that with just better prenatal care. You need modern obstetrics. And so you need an operating room and electricity. But this is not, if this is the beginning of a conversation, we could do so much and much more rapidly than we are. Same for laboratories. And I want to speed this up so there's time for discussion. And so a year after President Clinton and the ministry put us out there, we were pretty proud of what we'd done. By the way, these are two people doing training, but it's not the fake training that I see all over Africa and Latin America, where some big organization, usually, a huge bilateral, what they're called bilateral aid and multilateral aid, they're doing trainings again and again, but there's no there. There's nothing linked to the training. So it becomes just another sort of way of training people to do nothing. And that can be very demoralizing in my view. These trainers, one of them, they're both taking place in Rwanda, but one's Haitian. It's Dr. Leon, who heads up the HIV, STD, TB program in Haiti. He's now in Africa. And this is one of my proteges. He's an infectious disease doctor from Harvard. He's actually training people at work while they're working. And, this is the kind of training we should be sinking our efforts into. So a year later, when President Clinton showed up to see how things were going, we had a lot to show him. I should have chosen his shirt, but anyway. So he said, on this particular day, this is August 2006, I remember he said, all right, but that's just one hospital. This is just one country. How are we going to get this going? And the first slide I showed shows all those red dots in Rwanda. It's, again, taking this model to other parts of Rwanda. Right now, with the Ministry of Health, the Clinton Foundation, Partners in Health, we have rebuilt or are rebuilding hospitals and clinics in 3 of the 4 districts out of 28 where there were no hospitals. So soon Rwanda will have, as they planned all along, to have a district hospital in every district. And this is the vision of the Rwandans. We have a vision that's complementary. We have a lot to chip in, but it's their vision. And I think that's another important thing about the work. Now let me say, that of course the same things happen that we saw in Haiti. People dying of a wasting disease or 2 or 3 coming in and then getting better. This is a guy named John who has, again, HIV and TB. And I've said this before, but since this fairly recent set of photographs, I think I can say it again. He goes from looking like Skeletor to needing Lipitor. And I think that's progress. But we can also look at the whole cohort. And for those interested in the United States, as I am, how do you measure effectiveness with this particular disease? And again, these are not vertical programs, they're integrated. But this is one way to do it is to look and see if you can find the virus in the blood. And if you can't, that's called the suppressed viral load. And in nowhere in the United States do you get results like this, where 98% of the people after 2 years of treatment, and this is thousands of people, but these are the first 200 and something to go through. This is community-based care with the community health worker. You never see this. This is what you see. So this is from a friend of mine at Emory, who is again, at one of these meetings that we have all the time. He just looked at a group of inner city, that was the term being used, men, and I've been to the AIDS clinic there, which is a great place, but basically the upshot for this particular group of patients is they're not responding to therapy. And they don't have community health workers. We're looking at unemployment hitting 10% in this country and it's talking about stimulus package, we should train community health workers for the United States, not just for AIDS, of course, but for diabetes, AIDS, major mental illness, other chronic diseases. This is not the same as home health aides. These are people who are helping their neighbors. You can train them quickly. They maybe will go on, use this as a platform to go on to other things. So there's a lot of lessons that we could learn in Haiti and Rwanda and apply them right here, in my view. And this is the way, what we did. This is our program in Boston. It's just like the Haiti program. And there are some substantial differences around what problems people are facing, people who are living in poverty in a rich country versus people living in poverty in a poor country. We don't have food insecurity like you do in Rwanda, but you'd have, and they don't have, problems with addiction in rural Haiti that we do in the United States, but there's still social problems. And again, this model of having community health workers pitch in, I think, is very effective. Let me just give you one example, and then I'll go to close with some bigger questions. So here is basically, so it's kind of nerdy policy wonk slide. It's one patient, just an example. So the green line in the middle is where, this is basically, to put it in non-specific terms, it's a patient who's got AIDS, an American patient, doing very poorly. And the way you judge that is, the medical part is a lot of virus in the blood. It's called a high viral load. And the immune system is basically destroyed. But the red hatch marks are at the top are all visits to the emergency room. So this is not only bad outcome, it's very expensive to the hospital. In this particular case, it's a Harvard hospital, but any hospital, any public facility or private facility is really taken in on the chin when you have people in and out of the emergency room all the time. So the green mark in the middle is the community health worker. Same as in Haiti. We call them accompagnateurs often. And guess what? The virus in the bloodstream disappears, and so do the emergency room visits. And one way that I think as Americans we might want to think about this is it's very expensive to give poor quality medical care to poor people in a rich country. That's really one of our biggest problems. You could say we give no care, but that's not true. There are safety nets here. We need to understand how they work. But if they're not working well, it's very costly to the system, as we've all been hearing. Here's my last point to open this up. One of the reasons, I'm glad I hope that was a supportive laugh. It sounded kind of evil, actually. But, what's that? All right. This is a special school for lots of reasons. But one is that it's so focused on service that it's rehabilitated the notion of service in a setting of scholarship and reflection and affiliated with a major university. That's the right way to move this forward in Africa and the United States and everywhere, is think about the links that we could build between research and training, for me as a professor of medicine, research, teaching, training, whatever, but service is critical. And the standard model of a research university like Harvard is not really, it's not good enough to take on some of these problems. We're going to have to strengthen, as has been done here, we're going to have to strengthen our involvement in service. It doesn't have to be directly. If the universities want to have some sort of, they're risk averse, right? That's why, no offense to those of you who are lawyers, but, that's if you ask permission, it's very hard to get it for anything from a university. That's not true. I sound ungrateful. Actually, as you can tell, I'm really grateful to Harvard. Obviously, my dean at the medical school is strongly supportive of what I'm saying here today, that we need to link service. But of course, you do that in a medical school because you have the teaching hospitals. But think about all the faculties at a university and think about how many of them actually spend a lot of time and energy on service. So this is to open up discussion, and I'm obviously thrilled to be here finally, and I'm looking forward to having that discussion. Thank you very much.
All right. right, let's take some questions, and we have microphones, so would you wait until the microphone comes to you? We have a question right up here, Bob. He's going to get the microphone to you.
We need the Razorback track team to get the mics around. That's right, isn't it, Razorbacks? Sorry.
First of all, as someone who's trying to help, I thank you as someone who has helped.
Thank you.
And like I said, at Princeton's class day last year, I remember your comments. So thank you very much for taking the road less traveled and using your abilities to help and to construct, not to deconstruct.
Thank you.
Okay. Swords into plowshares. So something that comes from the Hebrew Scriptures. That day when we'll realize universal peace.
I don't want to interrupt, but we need to get to the question, please. We have a lot of people that want to ask questions.
Simply put, like you, I agree that social disparity, economic inequality can be solved. I see the similarities in your thinking with Jeffrey D. Sachs. However, I think there are three significant problems. And for the sake of time, internal, metaphysical, the destructive desire versus the constructive desire, say cursing versus forgiving. Second, inertia. You know, it's a problem, but does it motivate me to get off my couch? And the third would be a sense of selfishness, entitlement, short-sightedness. In order to act, we need something sufficient to bind us. President Obama has been appealing to what I call a base-level humanity, that we all breathe, our hearts all beat. However, I don't think it's been enough, and I don't think that will be enough to combat the destructive forces in our spirit, in our government, in the world governments. So what I'm asking is, what do you think is sufficient enough glue to bind us? And how do we achieve the critical mass within our country and within our world to truly bind us together so that we see that our struggles are their struggles and their struggles are our struggles?
Well, thank you for that easy question as an opener. I would make 7 points. No, I'm kidding. You know, I think it's a great question. I really do. I think it's a great question. I don't know the answer because, just like you, I struggle with this issue. But I will say one thing. I'm not so sure you're right that the destructive forces are going to outweigh, either internally or collectively, or even looking at a nation state, which is a difficult thing to do, right? To think about, because one of the answers people would give would be, well, what binds together is nationality. Well, that's difficult because not everybody in this room is bound by nationality. You may be, and I may be. I mean, I suspect we are by your accent. But I think that one of the things that surprised me in all these difficult places, prisons in Siberia, squatter settlements in Haiti, is that one thing that can bind people together is this is going to sound crass and not very spiritual, but effectiveness. I'm always stunned at how ineffective some of the good works and development projects are. They're not focused on outcomes, right? So if you let me say, if you invest a lot of talk in building something that doesn't get built, what's the destructive effect of that? This is something I'm very interested in. If you have ineffective programs, there's a cost there that's it's certainly emotional, as I said, just like overwhelming problems are emotional. But you could call that spiritual, whatever you want. So one thing that's overlooked that could bind us together is being effective together, pulling together to see things work. I think that's one of the things that's bound our communities at Partners in Health together with others is let's get some stuff done. Let's see some outcomes. And again, it doesn't sound very grand, and I did a better job being grand at Princeton, but it's a very important thing that we ignore at our peril, is we need to get the prescription right, to use a medical expression.
All right, questions? We have one right here.
Hi, thank you for your time in coming. But with the health disparities that we see in our own country, how can we begin to address it in other underdeveloped countries and do so seriously while there's time?
Well, I would say that that's another one of those either or things that we should be careful about, because that's why I closed talking about, our country, is you can learn lessons in other places that can be applied here. But on one score, I think you're dead right. If we don't address health disparities in our country, it weakens our ability to go back to the other question just posed. It weakens our ability to show that, to be effective. So my own wish, and this is why we have substantial programs in Boston. We're just starting another one in Alabama. We're going to be working in the Navajo Nation, again on community-based care. My own wish is that we don't make that choice, because of course we're living, if you look at, people talk about indigenous Haitians. Well, they're not indigenous. The people who lived there are long gone, but they were destroyed. And we know when it started in the late 15th century, and we know when it was over, and we know who was kidnapped to replace them, and we know all that stuff. So the boundaries of the nation state, as I said earlier, are they're political and administrative boundaries. In my line of work, infectious disease, swine flu doesn't care. They don't have passports to little influenza things. So I think that we should say we can do better here and we can do better there, wherever the here and there are. Now, bonds of national affiliation are important too. Like, we have a responsibility based on proximity. But I'm not sure that in the 21st century we all have the same notions of proximity that we did in the 19th century. So I think we can actually improve one by doing the other better, whether we're starting here or there, and also making common cause with each other, to learn lessons from one place and share them in another. Again, to focus on outcomes. That's what gives me optimism, actually, is that we can do that.
Questions?
Thank you.
It's right there, Bob. It's Senator Elliott.
Thank you. And before I ask this question, I will just say this for the benefit of the audience, because it's an opportunity that I introduced, and we passed legislation this last session to eliminate poverty in Arkansas and to uplift economic development. And people say it's a romantic attitude and idea, but I'm asking you to join me in this romanticism. So my question to you, though, is oftentimes we begin to assume that there's nothing we can do. And I have this notion that in our own state, while we're exchanging with other countries, which I think has value, student exchanges, I think it would be a good idea if we had student exchanges right within our own state as opposed to other countries, to help people understand that to be rich in my neighborhood many times is for somebody else to be poor. And I'm just curious about your thoughts about up-close exchanges as a matter of connecting our humanity.
Well, I think that's a great idea. First of all, I'd like to applaud your efforts to be serious about poverty reduction here. Now, up close, as I said, I've never been to the Arkansas River before. So this is the first time I've been up close to Little Rock. And I think that one of the best things we do, I always say this to students, to my own students, is, you're a student right now, or a trainee or a resident. You live in this city. You don't have to go to Haiti or to Rwanda to see, and this was your point as well, I know, see health disparities. And what can we do right here? Again, I'm very fascinated by notions of proximity and distance. Because inside one neighborhood, there is distance, right? There is difference between different families, different parts of a neighborhood, etc. So I think, again, that's what we need to push forward, is the notion of service, the notion of solidarity, the notion of helping others. I'm less interested. You're obliged to be interested in a state, but I'm less interested in international boundaries so much as boundaries, because we're really talking about social disparities, right? We're talking about race and class and gender and history and how it's structured over time, and that's a mouthful, right? That's a lot to consider in one sitting. But, and we were talking earlier today, there's a difference between social justice and charity, and we know that, and being open to history and understanding really in a clear-headed manner the cause and consequences of social pathologies, that's going to help us be more effective also in these local exchanges that you're talking about, I believe. That's what I say to my students who are in Boston is, we got stuff to do right here in these neighborhoods. And this project that I mentioned in closing, maybe a little bit too briefly, is really about what you describe. It's about neighbors in Boston helping each other. So, and I'm hoping that will be taken up. Thank you.
Questions? Yes, right over here. Let me take this over here. I'll get this to you.
Thanks, Dr. Farmer. I just had a quick question. That was, I appreciate your comments about focusing on treatment of patients with AIDS, but I'm interested to know what efforts is your group making to prevent the spread of AIDS?
Yeah. Well, the short answer is a lot. And I said I'd give you some good news about AIDS in Haiti. A friend of mine who's a doctor says, there's not a lot of good news about Haiti, there's not a lot of good news about AIDS, but here's some good news about AIDS in Haiti. We have used treatment also as a way of promoting AIDS prevention. One of the things that we saw, and I'm talking about AIDS, I could be talking about tuberculosis or, teenage pregnancy or whatever. There's a long list of pathologies. But let me just give you one technical answer and some numbers, and then go back to tougher questions. So if you, in this particular line of work, the expression is voluntary counseling testing. That jargon didn't even exist, 15 years ago when we started doing this work. But one of the most powerful ways to prevent the spread of HIV is testing so that people can know that they're, whether they're infected or not. And that's all agreed upon. But no one comes in to be tested if there's no treatment. So actually strengthening these programs makes it a lot easier, and that's why I showed that graph going way up of testing. So, but just to give you some numbers now, it is believed that HIV prevalence, the burden of disease in Haiti, has gone from about 5% of the population down to 2%. So I believe that by linking prevention and care, which was the premise that I started with, and I'll go back to the how and why and the tough question in a minute, that I think that's one of the main reasons that the size of the AIDS epidemic in Haiti has been halved. And that's, if I get, struck by lightning tomorrow, remember that I said I'm very, very happy that I got to live through that, to see the size of that epidemic in Haiti be so radically decreased. And I think we can do that in Africa too. As you said, not if we don't link prevention and care. We have to do that. Now, but HIV prevention is really difficult to do. And I'll give an example that often doesn't occur to people, is that one of the chief determinants of risk for HIV in Southern Africa is clearly labor markets. That's right, it's around mining and disrupting of families through labor migration. And these are sometimes difficult to see, but it's just so obvious if you work there, is that you have, if you look back in earlier part of the 20th century, how people lived in rural Africa is very different from now. And, why is it that there is so much HIV in Southern Africa? Is it a difference in the virus? That's called clade variation? Maybe, but I doubt it. It really has a lot to do with, again, disrupting of stable family units in the labor markets. So actually, it's going to be tough if we can't get involved in these efforts, and they have been involved more recently, for example, the mining industry. And if we can't make sure people, young men who go and have to stay in hostels for, a decade, it's not a very good way to, it's a great way to promote the spread of this disease, for example. And then, of course, tuberculosis follows, et cetera. So that's why is it that some of the highest rates of AIDS and tuberculosis are seen in the more wealthier part of the continent? Because it's not just the more wealthier, it's the more inegalitarian. There's a lot of wealth on that down in Southern Africa, but there's also a great deal of poverty. That's leading to labor migration. That's clearly related to the dynamics of this epidemic. My own academic work, which I didn't discuss at all today, is really about that problem. And the reason I don't discuss my academic work is because no one's interested in it, except for my mother. I went, back to those punitive footnotes. Maybe that's the problem. So think we got a long way to go with HIV prevention, but my experience in Haiti leads me to believe that the best way to move this forward is to link prevention and care, as we've tried to do. That means in schools and churches, everywhere we can, but also to acknowledge the complexity, the underpinnings of the epidemic really have to do a lot with social conditions and not just with individual volition. Obviously, individual volition is important too with all kinds of illnesses. But it's really, really tied to these large-scale social problems, and we need to fess up and acknowledge that, which is difficult to do because none of us were trained as practitioners. You know, a doctor, a nurse, or even a social worker, none of us is trained to take on these structural factors, as they're called. But as a society, together, you know, we can do that, I think. Back to your question.
All right.
Thank you.
Question. This lady's right back here. Yes.
Dr. Farmer, in your opinion, what's the impact of population growth on the health of the world's population?
Well, you know, first of all, the easy thing to say is, you know, there's too much population growth. And I'll say that. You heard me say it right here. Catholic boy that I am. We need to plan, you know, we need to allow people to plan, you know, women to not have 15 pregnancies. It's bad for them. It's especially bad for their health. So that part is easy for me to say. It isn't easy, and I'm not making light of other people's views on the topic, but the uncontrolled population growth that we see and high rates of fertility, it can be is very clearly linked to poverty. It's also linked to gendered poverty, right? So gender inequality and poverty are related to what I'm describing here. And again, I'm not being flip about it, but that part I understand. That said, you know, Tokyo is more crowded than rural Africa, right? I mean, Manhattan's more crowded than Little Rock. So, you know, there are complexities about how large numbers of people can live together with, you know, and how there can, you know, there's enough, people get enough of a chance, so there's not the violence that you see with overcrowding in Rwanda. I'm not saying there isn't violence in New York or Tokyo, but I'm also saying that I believe that, you know, the underpinnings of the genocide in Rwanda, which you also didn't talk about today, are related to land shortage and overcrowding. They're also related to very bad governance, which fortunately has been replaced by good governance. But look what happened in between. So the population explosion in that part of the world, the crowding, the fact that it was a peasant economy, the fact that you had people competing for incredibly scarce resources in a field of enormous poverty, that laid the stage for what would happen in 1994. And similar pressures obtain in Haiti, which is also rendered vulnerable by the ecological disaster that makes every hurricane season a nightmare. So how does that relate to population explosion? Well, you know, there are ways to live with high population density, but it's all very difficult to do with an agricultural economy. You need land to grow the things you eat. So we're clearly not on a sustainable path as a planet, as regions of the world. And I would go even further, and this may seem a little too grand, to say that the great social movements that I've seen in my half-century on the planet have been mostly fueled by people like Lindsay and those who choose to come here, which is the social justice movement around things like fair trade. I mean, I knew nothing about fair trade. I didn't know about anything about trade. And I didn't want to know about trade. I wasn't interested. I wanted to do medicine. But you should see the literacy, maybe you have seen. If you're a teacher, you've seen the literacy of students on campuses today about global justice issues, fair trade, debt relief, et cetera. So that big movement, if we can link that to the movement for environmental justice, I think we see some reason for optimism. This may be back to your big question, too, in the 21st century, bringing those together and having it be a very Big Ten approach where everyone feels that they could be part of this. That's, I think, then we can take on the population issue a lot better. Right now, what we have is we can't impose our views of population control or whatever it's called. That's the key word. Control is not a good thing. We're always trying to control poor people, and they don't like it. You know, they don't want to be controlled or told what to do. They don't want to be patronized. And there are respectful and solidarity-driven ways about talking about population explosion. We need to learn them and incorporate them into our everyday lives. Doctors need to, nurses, everybody needs to. So I think, yes, this is a huge problem, but we're on a collision course, with bad things. But we have to be focused on a much more respectful way. Yeah.
I'm sorry, we're running out of time.
I do what I'm told.
No, we could have 1,000 questions.
I'm staying around though.
Ladies and gentlemen, Dr. Paul Farmer.